Hello, everyone. My name is Angela Zoe, and I'm a CSPC Program Committee member. On behalf of the CSPC, a very warm welcome to everyone to the conference. We are about to participate in a very exciting conference session with the code 155 titled Responding Together in Real Time, Collaboration and Coordination in the Face of Public Health Emergencies, organized by Genome BC. Just before we begin, I do have a couple of housekeeping notes. Please turn off your videos and microphones. Please also note that this session will be recorded. There will be breakout rooms, but breakout room discussions will not be recorded. Please don't forget to tweet about your favorite events and panels at the conference at Science Policy and the hashtag CSPC 2020. And finally, in the chat box, I will be adding the links to a short survey that should take only about a minute or two to fill out. You can fill out the survey at any point during the session, and I highly encourage all of you to do so to help us make CSPC better in the future, especially as we're navigating this new online medium. Now, without any further ado, I will pass things over to Dr. Pascal Spothelfer, who is the moderator of this session. Thank you and enjoy the panel.
Thank you, Angela, and good morning and good afternoon to everybody. Genome BC is delighted to host this very relevant panel, and I would like to thank the CSPC for giving us this opportunity. I also would like to acknowledge that I'm joining this meeting from the unceded traditional territories of the Squamish, Tsleil-Waututh, and Musqueam nations where I live and work. The SARS-2 coronavirus pandemic represents the public health crisis of our generation. From initial emergence of the virus to lockdowns across the world took under 90 days. Public health officials, healthcare professionals, government officials, business leaders, and individuals across the world faced an unknown virus and had to figure out the rapid response by researching scientific evidence, establishing new clinical procedures, developing public health measures and policies, save lives and prevent the healthcare system, the economy, and systems we count on daily to collapse. Our panelists today all played their essential part to come up with responses. This session will shed a light on their insights, on the evidence they gathered, how the systems worked and didn't, and lessons learned so far. So let me tell you how the program will work. Each panelist will present for 8 minutes with audience poll questions after presentations 1, 2, and 3. This will be followed by Q&A breakout sessions with the panelists and Genome BC staff for 20 minutes. And just so you can choose your right room, let me give you kind of the subject matters that will focus the discussion on in the respective rooms. Room 1 is about the BC perspective and its translation into federal aspects. Room 2 will be more on the federal perspective and how it relates to the provincial, to the provinces. And room 3 will discuss the Indigenous perspective. This will be followed by a moderated panel discussion during which you can also direct additional questions to the panelists. Now, please let me welcome the panelists. I will keep the introduction short. You can find the detailed bios on the conference website. It is my pleasure to welcome Cara Tannenbaum, who is the Departmental Science Advisor at Health Canada, Colijn, Canada Research Chair in Mathematics for Infection, Evolution and Public Health at Simon Fraser University, David Patrick, Director of Research for the BC Centre for Disease Control and Professor at the UBC School of Population and Public Health, and Nell Wieman, Psychiatrist and President of the Indigenous Physicians Association of Canada. I now hand over the floor to David Patrick. David, please.
Thank you very much. I'm just going to share my screen. Okay, everyone, you should be able to see that. So in the next 8 minutes, I wanted to talk very briefly about our BC experience. The key take-home messages, just a moment, get my clicking going here. Yeah, are that there was some forward and advanced thinking and investment, and then some early investment during the pandemic that helped accelerate research in BC. And as a result, I think researchers have been quite productive and work is bearing fruit. But we're 11 months into this thing from the point of view of a research response, and it's important to consider the remaining challenges and actually two very big lessons for Canadian science policy. I'll start off by telling you about the evolution of the response. In the early days, we had a request from the provincial health officer to form an advisory group. I would say a bit of an ad hoc group of the usual suspects came together in BC and began to talk about collaboration, which actually helped quite a bit in competitive funding applications. But we got formal support from the Michael Smith Foundation for Health Research to form a strategic research advisory committee that was plugged into the province's incident command structure and continues to work with government, with the provincial health officer and the Ministry of Health. In BC, there have been other elements of the coordinated response. I would say that we have a pretty collaborative life science research community between the research intensive universities here. But this received additional organization through a structure called the Clinical Research Coordination Initiative that was organized by UBC, but included colleagues from elsewhere. We also have a BC Academic Health Science Network that kept an inventory of the research going, helped coordinate clinical trials and IRB reviews and so forth. And I think, as in most provinces in the country, the Ministry of Health was very busy with internal work on such issues as health system organization and unintended consequences of the response. Now, the scale of the research response went up logarithmically in BC. The early funding from Genome BC, Michael Smith Foundation, and BCCDC Foundation was in the millions and helped get diagnostics and modeling and other critical early things going. The Tri-Council contributions came in about a month later in the order of tens of millions, and that allowed the clinical trials and a number of other areas to develop. But we often ignore international and private capital that flowed into biotech, and I'm sure this was the case across the country, which has contributed to a lot of the developments we're reading about today. So BC brought in about 200 million in funding, nearly 500 projects now. And there's been more recently announced provincial funding in the tens of millions that can help fill some of the gaps that I'll identify for you later in this talk. Overall, though, there are opportunities that are bigger to change the face of pandemic response forever, and we need to learn those about those opportunities today. So within the BC response, we saw a lot of great action from our colleagues at the Public Health Lab and elsewhere on diagnostics. We've seen really strong viral and host genomic work, and I think we've got some of the biggest assembly of viral genomics data on this outbreak in the country at the moment. We've had a lot of effort with epidemiology and modeling. Dr. Colijn will tell you more about the latter.
David,
yeah.
Just to interrupt, you're showing a picture of a boat as opposed to your screen presentation.
You're kidding.
No.
Okay, I could think I can just, how do you like the boat? I'll tell you what.
Absolutely
stunning. Stunning.
Everyone loves the boat.
Getting rave reviews in the chat.
Is it? Okay. Are you still seeing
Nope,
that?
you're good.
No,
your
now it's good,
presentation's there. That's
but
excellent.
it's in that presentation mode.
Okay, is it in presentation mode?
No.
Yeah.
Oh,
No,
brother.
no, it's not. Now you're back to the boat.
You know what? I'm just going to keep talking through because it's the messages that matter the most. When we take a look at what we've been seeing as really important lessons that have been going on, we've seen pandemics hit Indigenous communities since 1492 relatively badly. And I'd like to point out important leadership by the Network of Networks in Indigenous Health by Jeff Redding from SFU and others, which is basically telling us that we can have Indigenous governed and led research going on. So that's important. There's also been a very key role of Canadian biotech with respect to the lipid nanoparticles that make mRNA vaccines work, the rapid monoclonal antibody production that is in clinical trials with Eli Lilly and elsewhere, as well as BC-based scholars working on recombinant soluble ACE2. Moreover, when we look around the world, we've seen the stunning success of the UK recovery trial, and I'll speak about the lessons we need to learn about that in a second. And of course, we're seeing vaccine trials galore with 2 mRNA vaccine candidates showing promise in preliminary results that have been released. Along with this research, though, we've also seen unintended consequences. We've seen school closures. We've seen overdose deaths outpacing COVID deaths so far. We've seen a delay of procedures in healthcare. We've seen economic disruption, increased unemployment, stress on the home front. And these problems have not been equitably distributed. Some people have sailed through, but other people in more precarious socioeconomic situations are suffering quite badly. And the important thing to remember is that this is not a zero-sum game. Sometimes we sit down and say, well, you can either control the pandemic or let the economy run. And that's simply not the case, because where there's been poor control of a pandemic, economies have suffered the most. So we identified some research gaps and short-term priorities in BC. Improving the process to recruit patients to clinical research is absolutely necessary. Evaluation and preparedness for vaccine uptake is critical. Therapeutics, including outpatient options, are becoming important. We've been quite good with researching inpatient options. And public health and healthcare management has questions of its own. Can we do better in long-term care? What are the most efficient ways to do public health interventions like contact tracing? Can we better protect and deploy our health workforce? But there are 2 long-term priority areas of significance to Canadian science. First, the stunning success of the recovery trial in the UK was based on pre-positioning of research coordination in something like 160 health facilities around the country, pre-existing contracts for pandemic response research, adaptive simplified protocols, and common IRB approaches. That's harder to achieve in a federation, but that's why UK recovery was first to falsify the hydroxychloroquine hypothesis, as well as first off the mark with dexamethasone. And secondly, we need to figure out how to move Canadian biotech into a full development and manufacturing capacity. That would mean that when we have a monoclonal antibody in development, it doesn't go south of the 49th, but we're able to be evaluating it in our own long-term care facilities and elsewhere. And we are less vulnerable to the vagaries of international trade when it comes down to vaccine and pharmaceutical supply during a pandemic. Overall, the take-home message with those is that we need Government of Canada and Canadian research policy input to realize those lessons and make a difference for the future. I'll stop there, Pascal.
David, thank you very much. And this would be the time for the first poll question, I think. So Charles, if you can put that up. And assuming that everybody has answered the question quickly, I can hand over the floor to Carolyn next.
Great, thank you. I still see the poll up, but maybe I'll move that window out of the way and share my screen. Okay.
I might have been too hasty.
All right, I saw a lot of warning signals, so maybe I'll close the poll and see if that's better. Okay. Oh dear. Okay, this is now for the first time ever, despite the fact that this is my 3rd or 4th hour of Zoom today. Zoom is saying that it can't record the contents of my screen until it is quit, and I need to quit before I share screen. So shall I quit and rejoin? I don't know why this is suddenly, I'd use Zoom all the time, every day on this computer, and I've shared screen many times. So I may quit and rejoin, if that's all right.
Sure.
Yeah.
Thank you for a few minutes of patience.
I'm back. I'll try one more time, and if not, I will just, there we go. Okay. I hope you now see this. Is that working?
Yes, we do. Thank you very much.
Great. Okay, very glad that that worked. I'm going to talk a little bit about the role that I've had and some of the science, and then I'll go to discussing the 3 focal questions that were posed for the panel. And thanks to David for the context around this, because it really sets the stage. So I'm one of the people in the group that is using funding from the Michael Smith Foundation that David described. And we're part of the modeling support team within BCCDC, but also as a broader academic group. And so I'll talk a little bit more about that. I just wanted to set the stage for BC with this, how it started, how it's going plot of our reported cases through time in the early part of the pandemic in March and April on the left, and then today, actually that was updated yesterday on the right. And you can see that, as David mentioned, we really took a lot of steps, of course, at the start of the pandemic, and we had a fairly widespread shutdown, which had an inequitable impact. One of the impacts that it did have was the primary one that it tried to have, which is to really squash that curve. And we didn't really have a first epidemic curve to speak of compared to what we're heading for right now. So the modeling group, and that was part of those fits that you just saw are part of this. Within BCCDC, we have a collaborative group that includes scientists at the CDC, Naveed Janjua and Michael Otterstatter, and then collaborators from SFU, UBC, the Ministry of Health, BC Children's Hospital, and a couple of super smart and wonderful volunteers based at the Department of Fisheries and Oceans. Turns out populations of things that are hard to see are, fish are one of those. And so there's quite a few overlaps with fish, the techniques that are used in fisheries and oceans, and the population modeling that we're doing. And then in BC, we also have a broader external academic group that spans mathematics, biology, statistics, engineering, physics, and industry. And we meet and we kind of get to use their ideas, and they get to hear our perspectives on what's happening. And it's been a sort of broad collaboration with a focal core group. And I think it's been effective. We do have somewhat indirect lines through to public health decision makers, partly through David and others at BCCDC and at the ministry. So I'm going to talk a little bit about some of the questions we've had and how this has played out in a little more detail. The first is this, what we call our social distancing model, and it's a compartmental model of how COVID-19 is spreading. It's pretty simple as disease models go. And it has this idea that there are some people who are willing and able to engage in social distancing. They maybe don't have to go work in the healthcare sector, or they're able to work at home. And they are less likely to go out and contact other people. And when they do, they're less likely to bump into other distancers. And so there's a cartoon representation of that. And then as things reopen and as we change our policies and we change what's shut down and what's not, then the contact rate among through the population and among the distancers changes. And that drives cases, being able to go up or go down. So through the pandemic, we've been fitting this model to data, and these come out in Dr. Bonnie Henry's slides. And here's one that I think is interesting. Because we have this notion of what's the contact rate among people who are willing and able to distance, we can think about how that changes our future scenarios. And these have been used throughout. And I think they're a great tool, because one of the things that studies, including the iCare study, have found is that the public likes to be able to see how our actions are going to make a difference. So saying, what happens if we go out and contact others and we have too many contacts? Then we will see these rises. And that's probably more like where we are today, this exponential rise. These also go through to the Public Health Agency of Canada. And I compile them at a national level. I fit the provinces with my team, and we send them out to IPAC. And then sometimes they get embedded into Teresa Tam's slides. So you probably remember the Crossroads framing a few weeks ago This is one of these where we take this model and fit to the different provinces, and then we say, what are the scenarios? So these aren't really predictions, they're extrapolations of what happens if we do certain things. We can't predict policy and behavior, but we can show the flashlight view of the path that we're on and where we're headed if we don't change our direction. And so these go out, and these have been used. Some of the questions that have come down, the natural one is what's happening and what happens if we keep going and what happens if we change. So we use models to answer those questions to the best of our ability. Another set of questions we've had that we've thought about is contact tracing, and I think it's really topical right now. So I wanted to discuss it a little bit. How effective can contact tracing ever be in Canada and jurisdictions like Canada, where in order to start contact tracing, first what has to happen is someone has to get symptoms and then get tested. And then there's a turnaround time before they get the test results. And then it takes some time to find and contact their contacts. So this is a cartoon. We've used some kind of realistic numbers, we think, but someone can infect others before they have symptoms. And so that person then starts maybe being able to infect tertiary cases. But if we wait until symptom onset, test results, and contacts informed, actually it's only this little green part and this one potential transmission that we're able to stop, no matter how much we do, no matter how many contact tracers we have. And we can think about, what's the fraction of new infections you can ever stop by contact tracing in an environment like Canada, where you're testing symptomatic people, and that's when you start contact tracing. It's not a lot. Even if you do contact tracing instantly from the time of positive test, and you do as much as you can still only get, 20 to 40% of the cases. So if we reopen to the extent that the R value is 2, this will never work. I think these are kind of important realizations that the math was known, back at the start of the pandemic. I think what's new is that the level of reopening required by Western liberal democracies, I think, is pretty much always beyond this point where this is going to work. And then, of course, you can't do this infinitely. You can double your cases every 14 days, but you can't double your contact tracing team numbers every 14 days. So there's a tipping point there. Okay, so I want to step back a little bit from those kind of urgent questions and the kinds of things we're thinking about, and spend the last minute or so, assuming I still have a minute, to just speculate a little bit on the questions. So the questions that were kind of at the heart of the panel were about how to better coordinate the timing, the processes, and prioritization of real-time support for public health decision-making. So I think timing is a really interesting one because, at least for the research, there's just a time mismatch between when policymakers need answers and how long research takes. And math modeling is probably the fastest kind of research because you can make a model in your computer tonight and you can stay up all night and you can get an answer from it. Whereas if you want to do health research, clearly tonight is not the time frame that is of interest. But even with math, there are these short and long-term kind of contrasts. And I think building a network of expertise and a kind of database or coordinator of that expertise, such that when really urgent questions come along, who will know the answer today or will be able to get the answer today, rather than starting from scratch and saying, okay, so now I'm going to figure this out. Processes, I think, have been really interesting in BC, and one of the real strengths we've had is in the data flows that we have been able to clearly articulate. What are some of the data gaps? If you wanted to answer that question, what would you need to know? And in many cases, we've been able to coordinate the data flows within BCCDC internally to access those data. And I think another great aspect of the process is really, and how to better coordinate it, is around communication and having inclusive and rapid communications, such as through simple tools like Slack, I think have been really helpful. Everyone can see the conversation, they can jump in and out, they can see the previous conversation, share figures and share asks and share things that are going out of the team without having to remember who's on what email chain and have it in the deluge of emails. And prioritization, I think, is really important. And I think that's maybe where we've had somewhat more of a gap. I think kind of broader strategic priorities from decision makers And a knowledge of their constraints and their needs would probably enable us not to model things that are kind of completely wishful thinking. Oh, if we tested everybody, how great would that be? That's clearly not a relevant question in BC right now, and so on. So I think throughout these three themes, one of the better ways to coordinate them, in my view, would be to really embed academics and, from our point of view, modelers and people who are doing estimation in teams together with public health epidemiologists, with implementation, people doing implementation, and also with decision makers, so that those conversations are more immediate, so that the strategic constraints and priorities are identified and more well known, and so that researchers can anticipate needs a little bit better to match that short and long time frame contrast. I want to thank obviously the BCCDC and our folks from Fisheries and Oceans and the other institutions, and funding from Genome BC, of course, who also supported this panel, and the Michael Smith Foundation. So thank you, and I will stop there.
Thank you very much, Caroline. And so Charles, if you could put up the second poll question.
Would you like to see the results of the first poll, just out of curiosity?
Sure.
Yeah, I'll just share those quickly.
Thank you. And the second poll. And Charles, can you give us the go ahead when we can move on to the next segment?
Absolutely. We'll just give another 5 seconds. And we're good.
Thank you very much. Okay, so I'll hand it over to Nell Wieman for the next presentation.
Great, thank you. I am just, once the poll closes, I'm going to share my screen. Oops, hold on. There we go. Can people see my screen?
Yes.
Okay, great. And hopefully that will work. So bonjour Ani, everyone. I know we've already been introduced, but my name is Nell Wieman. I'm the acting Deputy Chief Medical Officer at First Nations Health Authority here in British Columbia. And I'm also, as was mentioned, the President of the Indigenous Physicians Association of Canada. And just before I start, I'd just take a moment to acknowledge that I am Indigenous, but not on my ancestral territory, which is Little Grand Rapids First Nation in Manitoba. But I respectfully acknowledge the land on which I work, live, and play is the traditional, ancestral, and continuously occupied territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh. So I'm going to take a little bit of a different approach to my part in the panel and give a broad overview of Indigenous health research or research in general, and then hopefully in the breakout room be able to have a more specific discussion, for example, around the pandemic. I think it's important for conference attendees to know that, here in British Columbia, we are dealing with 2 declared concurrent public health emergencies, the COVID-19 pandemic and the opioid crisis, both of which, and especially in some ways the opioid crisis, Indigenous people, First Nations people are disproportionately overrepresented in those in the crisis, and indeed in the pandemic, as we see across the country. And the third sort of intersecting crisis, if you can call it that, is the here in BC, we are engaged in a provincial inquiry into racism in BC's healthcare system. So all of these 3 major things that are going on right now are kind of intersecting all at the same time. So I'm just going to talk, I'm going to give an overview quite briefly, and then hopefully in the breakout room, we can have more specific discussion. So those of you who may remember the Institute, when it was called the Institute of Aboriginal People's Health, which was one of the institutes of the Canadian Institutes of Health Research, around 2007, 2010, created these guidelines for health researchers working with Aboriginal people. That has since been replaced by a much more fully realized Chapter 9 in the Tri-Council Policy Statement of 2018. And some of the overarching principles now are more well-known than they were in the past. For example, it's important to develop reciprocal accountability, trusting and respectful relationships, whichever community, whichever Indigenous community it is that the health researcher is wanting to engage with, whether that's an on-reserve community or off-reserve. You know, the reality is that over 50% of Indigenous people live in urban or away from home areas. So there are studies, for example, going on here in British Columbia that involve people who use substances or people with lived experience of using substances, and they mainly have come from the away from home or urban population. So engagement and collaboration is very important, and also maintaining respect for Indigenous people's knowledge and systems, and how our worldview may be a little bit different, but still add to the richness and the complexity of the research that's undertaken. In some ways, it's even harder to be a health researcher when working with Indigenous people than it was many years ago. There was a very kind of negative pattern of, you know, kind of going into a community, doing your research, asking really intrusive questions, or even taking biological samples, and then the community would never hear from that researcher again and wouldn't really know what happened to the results that were published. And in some cases, there were some particularly horrific experiences here in British Columbia where biological samples were used for secondary purposes without consent. So there is a much more time-consuming in some ways, but necessary way to go about engaging with Indigenous communities to do research. And I think I've talked a little bit about the two-eyed seeing approach. So this was a term that was coined by a Mi'kmaq elder, Albert Marshall, about 16 years ago. And it really talks about respecting both what the Western medical point of view and acknowledging the richness that happens when you acknowledge Indigenous ways of knowing and Indigenous knowledge. So I work at First Nations Health Authority in the Office of the Chief Medical Officer, and we have one of our key roles is to be watchmen. And what this means is if you Google that term, you will see a picture of a totem pole, typically, that has three characters at the top, three figures at the top wearing quite tall hats. And these were the watchmen. And so our role in public health at the First Nations Health Authority is to be those watchmen. So we watch outside of the community for harms or risks that may happen. And we also have a figure turned into the community who reports, and in some ways it's called chattering that alert, so people know what's coming. And this model in some ways is quite interesting when we think about what's happening with the COVID pandemic. And we also have many other areas of interest of research that are detailed here. I won't go into detail now, except to point out that we have very robust data around the opioid crisis. And there are periodic public releases of that data, because what was mentioned earlier is the data governance piece around research findings is very key and important. And so we can't necessarily always release data right at that moment without going through the proper channels and protocols But we do for different health issues. For example, the opioid crisis, I believe the last public release of First Nations specific data was in July of this year. And I think I'm just about 30 seconds under my time. So all of this to say, you know, I think right now we are in a kind of a very concerning period with regards to the COVID-19 pandemic. As was shown in some of the mathematical modeling and in David's talk, you know, we went through, I think here in BC, a period where we were feeling pretty good about how we were managing the pandemic, and our daily case numbers were quite low. And unfortunately, over the last month or so, we have seen quite an accelerated increase in the daily number of new cases, and the same would hold for First Nations communities. We have seen clusters increase in different regions of the province. And this is particularly concerning for a number of reasons, partly because we have this historical experience of being quite devastated by infectious disease and epidemics and pandemics. And also because the people who are seen to be among the group that is most at risk are the older segments of our population. And for us as First Nations people, these are typically our elders, our language keepers, our knowledge keepers. So really a key and vital human and cultural resource. So we are really motivated to work towards bringing our case counts down. And I am grateful, as I end, for our numerous partners that we work with at First Nations Health Authority on this work, both with the pandemic and with the opioid crisis. So I'll end there. Thank you, Miigwech.
Thank you very much, Nell. So Charles will put up the results of the second poll question. And well, that's pretty unequivocal. Now, Charles, if you could put up the third question, please. And please give me the heads up when you can pull down the survey.
Getting very, very robust response. I think we're good.
Excellent. Thank you very much. So over to Cara.
Hi, everybody. It's my pleasure today to share with you an amazing experience that I had, quite frankly, in setting up what's called CanCOVID. And for those of you who don't know, CanCOVID was a novel science to policy online communication platform that we set up in the early days of COVID. So I assume you could share my screen. You could see it?
Yes, we're good. Thank you.
Everyone else has trouble. So it was actually launched on April 1st, and it was created to foster rapid transdisciplinary collaboration, coordination, and communication among Canadian researchers, clinicians, and decision makers in the response to COVID. And the overall vision was for researchers or academics to work better together with the federal government so that decision-making folks will have timely access to researchers and their knowledge and their expertise to move forward in the pandemic based on the best available evidence. And I can tell you that today there's about 2,500 members of CanCOVID, and it's 3/4 academic, but still a large proportion hospital. It says 6% government and some industry and others. But I'm going to back up and I'm going to tell you how it all started. And it really began as a solution finding exercise in the early COVID chaos. And you'll remember that CITR launched its first, rapid response call, as David mentioned, and people were getting funded. But it's not, I like to say, it's not like there was a network of COVID scientists available or a specific academic meeting that was going to happen where scientists were going to speak to each other. So this idea of the need to connect researchers who are all working together on the same SARS-CoV related challenges came up. At the same time, what we were hearing is that as government was making decisions, a lot of scientists, particularly infectious disease scientists, but also others, were saying, well, why are they deciding that? I kind of see it a little bit differently. Do government folks understand the science? And are they asking us? How can we tell them what they need to be thinking about? And then in my role as departmental science advisor, I personally was getting a lot of phone calls because I knew a lot of people and I worked with Mona. Mona was getting phone calls, from the government folk, but we certainly didn't have the expertise, at least I didn't, to answer all those questions. The task forces, the federal task forces hadn't been set up yet. And so how do you coordinate all this is really the question that happened. And I looked it up with a colleague of mine, Sarah Gallagher, and it turns out that it was on March 20th that I was speaking to Mona right after one of her health expert panels. Carolyn's on that panel, and at the meeting we were saying, so who's doing what and how do we connect people? And if we're going to be checking for immunity, then who has a cohort study? And we said, wouldn't it be great if we could get everyone together to share what they're doing? And I spoke to Sarah right after, and she said, oh, I know a guy who knows a guy. It would be really good to use Slack. Can we really set that up? And then she knew Mark Daly, who knew Vivek Goel, who knew Alex Michaelidis, who knew Hallie Siegel. And to make a long story short, over the weekend, we kind of hatched this idea of making a coordination platform on Slack. But how would we get the researchers to buy into it? A few days later, we were speaking to all the vice presidents research of the U15 saying, do you think this would be a good idea? And they said, well, there's also the academic hospitals, you should ask them. And so with a million phone calls, everyone said, yeah, I think that might be a good idea. Why don't you give it a try? And by March 26, we heard that we needed to bring in members from the Public Health Agency of Canada, representatives from all the different sectors, and start onboarding moderators to the Slack platform, which is, as Carolyn was saying, a platform where you could see what people are saying. It's sort of like a radio channel. For those of you who don't know, and you just kind of turn the channel and then you hear about, I don't know, the vaccine, or then you hear about something else, you could see it all in writing. And on April 1st, we had launched. So what were the challenges and why might it have worked? Well, there was urgency. People were dying. I was actually working in long-term care at this point and very sadly saw a lot of people die. So this urgency, I think, really sparked the collaboration, and it was complex. We needed social scientists, we needed infectious disease specialists, we needed basic scientists, we needed modelers to help inform what was going on. And there were also disparities happening that we wanted to address. So how do you do all that? You need speed, you need insight, you need coordination, you need fairness. And we developed a collective leadership model to this, and we got the digital collaboration tools. We used Google Docs. We made sure we had a transdisciplinary membership. We were rigorously committed to diversity and inclusion, and we started co-creating not only knowledge by sharing with each other on the platform, but also mobilizing that knowledge into policy briefs, what we called insight compendia, synthesis reports on cross-cutting issues. These were our analytics from the first 2 weeks. So within the first 2 weeks, we had over 1,000 members, which was kind of crazy, people signing up. They were vetted members. And the green line that you could see on the screen is how many active members there were on the platform per week. And, over 700-800 people were chatting. But what I learned is that there was also direct messaging. So if people didn't want to chat in front of everybody, they were able to I guess just reach out to someone individually. But what I also found out is that even if you weren't contributing, it was kind of like going to a conference where you saw the experts talking and you just looked and you took in the information, even if you weren't contributing. So that was kind of cool, I thought. We had different themes or different channels, if you will. Some of them were more popular than others. The Indigenous research channel was extremely, extremely well attended to. And I'm going to tell you a little story about that. The community really came together. You heard Neil say there was a lot of concern, and we thought that this was a great way for people to connect. So what did we do? We, oops, sorry, the graphics for some reason didn't come out very well there, but we said, well, what if decision makers posed a question? Would we be able to share that question with all the members and see who wanted to feed in an answer? And at the same time, members were identifying information gaps and concerns. So we crowdsourced that information, we compiled everything, and then we either, well, we pretty much fed it up to whoever we thought needed to get the advice. How did this work? Well, here's some examples of the kind of crowdsourced documents that we gave back in April, even before, Black Lives Matters happened later. Already people were flagging to us that Canada wasn't collecting race and ethnicity data. And we collected information on what researchers thought the government should be doing. And we handed that up to Teresa Tam, who shared it with Statistics Canada. When they set up the immunity task force and everyone was talking about seroprevalence studies, we crowdsourced a document and asked, how might Canada avoid the design flaws of studies being designed in other countries? And got a lot of answers, and we sent that to the immunity task force. And you could see some of the other topics that came up. Sometimes we sent crowdsourced documents, sometimes with the help of Mayen Yu, who we were fortunate to have. Mayen works with me as a strategic advisor for Health Canada, and she understood how to translate academic speak into government speak. So she helped maybe digest this and put it into issue notes, and then we sent that back to the COVID task force and elsewhere. This is what a crowdsourced document looks like, just if you're curious. It's a Google Doc. So we would just say, new question, from your perspective, what are the key challenges of running multiple simultaneous vaccine trials in Canada? How might the issues you identify be best addressed? We asked academics to identify themselves in case the government wanted to follow up. And they pretty much just wrote what they thought, and then we sent in the raw data like that. And if you wanted to follow up or find out if there was a conflict of interest, people were able to contact them directly. We quickly, once the COVID-19 task force was set up, we established connections, again, mostly because of who knew who, and I'll give a shout out to Mayen again, who would just call and say, look, what are you guys dealing with? Do you have any questions that you need answered? And they would say, yeah, can science answer these questions for us? Can COVID help? And you could read the questions. And then we would just put it out there and say, is there anyone who has thoughts based on science? We asked them to use citations. We found ourselves looking more and more towards the social scientists to try to answer some of these questions. And this one in particular was workplace scientists. And within a week or two, we were able to send back information that we were told was extremely helpful as government developed its back to work guidelines. I think this was, maybe in June or something, just as the lockdown was finishing. Other examples of what worked well was the government in Ontario was about to launch a data platform called Panther, and said, is this the way we should do it? Could we get your insight? And so we went to the modeling channel and said, this is what Ontario is thinking of doing. Do you guys agree with it? And they had some comments. They actually crowdsourced some recommendations. And then we got some of the Ontario Ministry of Health folks to connect to get feedback. And my understanding, and I was told that the plan of what the Ontario government was going to do was modified slightly because of this input in order to address concerns and make the data more accessible to modelers. I'm not saying it's perfect, but I heard that it was definitely an improvement. What CanCOVID also did was look at which questions weren't being answered. And this is an example of a conversation from our Indigenous channel where they started asking really on, well, what about people in the north? There's no mobile labs for for COVID testing, and how do we get labs up there? And the academics didn't know. So we brought that question to our governing council, where Karen Dodds was able to connect us to folks from Fisheries and Oceans and the Department of Defense. And we were rapidly able to mobilize an action plan around that, just from the connections and coordinations of everyone who was on the platform or on the governing committee who knew other folks in government. We launched a speaker series so that anyone who wanted could find out the most recent scientific information. And at times we had over 200 people. Actually, I think for Bonnie Henry, we might have even had 400 people when we interviewed her early on in the pandemic. She's a great popular gal. You know, and we covered different topics. We worked on science communication. We put out infographics and state of the science report because we thought that's how things should be communicated in those early days. And my last slide is really a reflection on, you know, the timing, the coordination, and the process. So why did this work? I think it worked because the leadership was diverse and well connected to government and academia. So we brought in the vice president's research. I knew folks because I've worked with CIHR. I knew government folks. I'm on great terms with the deputy ministers. And everyone, I think, just believed it was important to go out and do this. There was no funding. I forgot to mention, there was no funding. This was all in-kind support. So lots of one-on-one phone calls, a sense of urgency. There was really no bureaucracy. And, you know, when it comes right down to it, I think that might have been one of the reasons for the early success. The use of technology broke down silos. I think government was able to participate without worrying too much about documents and risks. They were able to see the science. They appreciated the rapid response. And at the time, no other structures really existed to respond to COVID-19 in terms of collaboration. Certainly the chief science advisor had a health expert panel, but at the time, the reports and the discussions were not being made public. They are now for anyone who wants to go check those out. But then over the summer, the activity waned, task forces were set up. Now CanCOVID phase 2 is up and running again, and they have tons of systematic evidence queries and real translation of that evidence. But it was a pretty amazing experience at the beginning. I like to think, you know, when this is over, the same thing could happen with climate change or water management or something like that. But we'll see what you guys have to say about it. That's what I had to contribute, and hopefully there'll be some lessons learned for the future. Thank you.
Thank you very much, Cara. Thank you to all our panelists for their tremendous insights. And so we'll move into the breakout rooms. And just as a reminder, breakout room 1 will be about the BC perspective, and it will be David Patrick in that room, joined by Sally Greenwood from Genome BC. The second room will be more the federal perspective and how it reflects on the provinces. And it will be Colijn and Cara Tannenbaum, joined by me in this room. And finally, Nell Wieman and Genome BC's George Poulakidas will be in room 3 on the Indigenous perspectives. So you can choose your rooms yourself, and we'll keep it at 20 minutes, although we're a bit late, and we'll shorten down the panel sessions at the end. But I believe you have more interactive sessions in the breakouts than you could have in the plenary. So please choose your breakout rooms, and you will get a 5-minute warning before the breakout rooms close and you come back to the plenary. Thank you very much. Okay, Charles, can you sort us out, please?
Well, in our session, we were just getting to the crux of it. It was sort of like the holy grail. We were talking about how do we make, policymakers understand the science better and scientists be more action-oriented for policymakers. So that was a great point to bring us back here. Pascal, I'll pass it back to you, but I was getting pretty excited there.
You're doing a wonderful job, Cara. Just keep going in that direction. I think, unfortunately, we only have about 15 minutes left in our session, and I agree with you. In the breakouts, you really got into the crux of things. So I don't want to interrupt the flow. So if anybody in the session has a question that they carried out to the breakout room, if any of the panelists have a question or comment they carried out to the breakout room, please go ahead. David, please.
Yeah, Cara, I'd like to build on that to a certain extent. I mean, part of it is that we have had a dichotomy between the healthcare system and the research system. And what I was getting at with the British is they decided to break that down. And by prior investment from NIHR, most large facilities in the country, not just the typical teaching hospitals, were ready to conduct research in the event of a pandemic emergency. And that's because the contracts were pre-written, the protocols were thought about in advance, the agreements were all there, the IRB thing was all put together. That's a big thing to do for Canada, but it's not just a way to think about pandemic and emergency response and getting the clinical trials done quickly and that kind of thing. It's actually something that would make us way more competitive for evaluating drug treatments globally and give ourselves the chance to stop being a startup biotech economy and be a full spectrum healthcare industry with the ability to support trials that would allow us to build a pharma and manufacturing capacity. So I don't know. Canada's shown a lot of strengths, but looking overseas to the UK, they showed us how to do preparedness for the 21st century. Research preparedness.
In a sense, that kind of poses the bigger question. There is several things we have learned over the last 11 months, 10 months, and a lot of these lessons certainly apply not only to potentially a next pandemic, but also for the times in between. So one of the questions I think is, how do we truly have a learning healthcare system, for instance, as one question, and do our systems adapt, and how much of this learning will we carry over into the future?
It's a good question. Does anyone here have an answer?
I think it's key. There's the big question is what have we been learning by this pandemic, and it's that we've got second to none startup capabilities. We've contributed magnificently to the vehicles that drive the vaccines that everybody's talking about, and to drug development and so forth. But can we do the clinical trials ourselves? CIHR did a great job of getting our networks funded, but our recruitment was pretty slow because of the balkanization of approvals and the lack of pre-existing capacity. And unless we're talking about, the Sinai Health System, the University Health Network, UBC, McGill, but it really, most larger facilities in the United Kingdom participate in that learning health system model because of the pre-investment by NIHR. So I think CIHR needs to look at that. And Health Canada has a role because our regulations around clinical trials leading to approvals need to be at least examined for simplification.
So as a shout out, CIHR now has an open funding opportunity for a network of clinical trialists across the country. Yep. So maybe we'll be able to get our ducks in a row for next time, although I agree with you, we more or less failed this time. What strikes me is that maybe we need to redefine the metrics that either encourage or hinder collaboration as well. Because at least for academics, we live in a very competitive society where, only those who are excellent gets funded. By definition, excellent means that you exclude the other 90%. And there's probably hindrances to collaborating both within provinces and across provinces. I think we could do better. I certainly am committed to bringing these conversations forward, but I'd love to hear from somebody who works in government. I think it's probably easier for academia to maybe make these networks of networks, maybe, I don't know, but in government, what could have been done better? I know that we have some folks, at least in the panel that I was on just now, who work in government. Does anyone have any thoughts about what could be built back better from inside government to facilitate the science to policy interactions?
I can give that a shot. It's Matt McLeod from Defense Research, but I'm in part of Defense Research where we do, just on an ongoing basis, embed small teams of researchers directly with various clients. And this, speaking of crises, this came out of World War II, where academics were brought in to directly advise military folks, and we just kept doing it. And so even having groups of like 3 or 4 people with major decision makers, we intentionally hire people with a variety of backgrounds so that when a question comes up, even if we don't have the right people in the team, we know each other and have been able to reach across and get some of those expertise. So we had actually no one embedded with health services at the beginning of the crisis, but enough expertise was brought together rapidly, and now there will be more of a permanent team there. That just, yeah, having those researchers embedded with decision makers ready to go is hard to replace.
So that's really interesting. Maybe you could expand on that. I know that we've piloted through CIHR what we call a policy researcher partnership type of grant, where we ask academics to be assigned to a unit at Health Canada for a year or 2, but that's not what you're describing. Are you describing hiring people out of academia, or do they have one foot in academia and one foot in government? I'd be curious to hear more.
We're hired as government research scientists. Defense has its own category for historical reasons, but so we're sort of like defense research has labs as well, but we do have a center called the Center for Operational Research and Analysis that's made up of these small teams distributed throughout the rest of the department, providing that close contact advice. And yeah, having those, it's almost like a military rotation. Like we tend to move every 3 to 5 years, and that gets you speaking the language of the people you're with. Like it's hard to just sort of jump right in with 2 months notice and really make those connections locally.
I think another area that we have identified is the data gaps. And I know it's difficult, the health care versus research dichotomy that David mentioned, and we also have a provincial versus federal dichotomy here in Canada, and it's hard to get data moving across, both from health to research and from province to province and from province to national. And I think, we're still using estimates based on data released in Tianjin and Singapore early on, because those are some of the best, most connected line list data where there's contact pairs, and the whole world is using estimates for COVID transmission that are based on those 2 early data sets, and we don't have any data sets like that for Canada. And similarly around real-time indicators of behavior and social distancing and public opinion and all kinds of different data. I think we've developed a sense of which kinds of data we could use to answer which kinds of questions, but we still have, I think, some pretty big data gaps across the country in terms of how data are collected and whether they're shared, even internally between health authorities and an organization like BCCDC, between provinces and PHAC, and then between people who hold the data and researchers who would be able to contribute but can't get access to those data.
And this is something that we should have learned out of the SARS crisis in the first place, and was supposed to be addressed to have a better data integration across the country. So what kind of things do we have to envision now to make it happen this time around, that we're not sitting here 10 or 15 years from now, hopefully, or 20 or 30, having exactly the same question?
So Pascal, let's talk about failures then. I mean, and be honest. One of the reasons that Panorama as a public health information system didn't really fit the bill that everybody hoped it would after 2003 was we went with the big IT model, IBM, very top down. It didn't really begin with the frontline workers and think about the data flow in terms of what needs to happen to get the obvious transactions done. I mean, it does a lot of good stuff, but it has not been fully adapted. So we either need to think about a different way to pull systems together that start at the grassroots and build up to the research capability, or we need to allow systems to talk to each other more coherently using machine learning for translation and that kind of thing. But we did have that huge ambition with Panorama, and I would say, in honesty, it's not been fully realized. We've got a lot of data flowing within BC by other systems right now, and that slows us down too.
I think system is a challenge, but also another challenge is also translating the data and research into something usable by decision makers. So with Health Canada collaborates with CIHR on this drug safety and effectiveness network to try and provide evidence on drug safety and effectiveness. So it's been there for years, and there has always been challenges of how do you sort of use the research that is done by scientists and sort of make it into something usable and tangible that can sort of translate into policy. So I think that's always a struggle, because the sort of the goal, it's really different, or when you develop a policy versus when you develop a scientific research project.
Yeah, and also wonder if given our federalist structures and the challenges of data flows, whether there is a role of the federal government from a interventionist point of view to break down of these barriers, some of these barriers down deliberately and proactively.
Well, I don't know if any of you have read the Fit for Purpose report by Daniel Martin and PJ Forrest, and it sort of talks about, you know, how to how to bring together all the different federal entities and make sure that there's coherence across Canada with the provinces. And in the introduction, what really struck me is that they said the Canada Healthcare Transfer Act, I mean, we do transfer federal money to the provinces, and they said there's nothing legally that's stopping there from being teeth to that. In other words, you don't get your money unless you make your data available. However, my understanding is that there are some serious political considerations that prevent that kind of, I would say, stick from being handled. But that struck me as a very interesting way forward for the future. But there's a reason I'm not a politician, and probably, you know, be kicked out if I suggested that. So I'll leave it up to you, Pascal or David. You're probably a lot more politically savvy than I am.
You sit much closer to the people who may make these decisions at some point in the future. So I think we have about 2 minutes left in our panel. And instead of being rudely interrupted as we were in the breakout rooms, I would like to take the time and the opportunity to thank Cara, Colijn, David, and Nell, who had to leave a little bit earlier, for their insights. And it's really encouragement to continue that conversation, because it's the mix of experiences which I think will allow us to be much better prepared for the next one, which is pretty much inevitable. And it's to Cara's point in the CanCOVID organization, it's multidisciplinary, it's multi-jurisdictional, and it's open communication that really makes a difference. So I really appreciate all your contributions. I also appreciate all the other attendees' interest in the subject. And please take the messages with you, and including the power of the infograms out into the public, and let's fight this pandemic together. Thank you very much for your contributions, and thank you for CSPC for allowing us that panel. All the best. Have a great afternoon. Bye-bye.
Thank you, everybody.
Thanks for having me.